Well, good afternoon, everyone. I'm Mary Vignola, the director of the Hunterdon Health and Wellness Centers located in Clinton, White House Station, and Lambertville. We would love to welcome our membership family and community friends. Thank you to our presenters from the Hunterdon Cardiovascular Associates group for speaking about the importance of heart health. I would like to now turn the presentation over to Amy Watson, our physician liaison with the Hunterdon Healthcare System. Amy?
Thanks, Mary. Good afternoon, everyone. And thank you for taking the time to join us today. Just some housekeeping. If you have any questions, you can enter in the chat box, and we're hoping to answer as many of them as we can at the end of the session. I would like to extend a very warm welcome to three physicians from Hunterdon Cardiovascular Associates. We thank you so much for joining us today. I'm very excited for your presentation. They've got three locations actually in Flemington, Bridgewater, and Clinton as well. So Dr. Elnahar, Dr. Tewari, and Dr. Garcia, thank you so much again. And I'm going to hand it over to Dr. Elnahar to get started.
Hi guys, good afternoon. Thank you so much for inviting us and having us be part of this educational thing. It's in the COVID world. These are different. Previously, we did these live, so we'll try to make the best of what we have. So we have a couple of slides to share with you, and if there's any questions, feel free to interrupt at any point. We'll start. My focus in my 8 to 10 minutes that we get is women's health and some general trends of where we are in cardiovascular disease. So this is going to be very brief, but kind of informative on some of the big picture ticket items to consider. First, if we look from the 1979 to 2013, so if we look over this period of time, 20 plus years, what you see in blue over here is trends for males and trends for females. And it's a disease that affects obviously both women and men, but it's completely different, our understanding of it, and I'll go over some of that. If you look over the years between 1979 to 1990, there was a decline in men's mortality. So this is deaths in thousands. Women during this time, ironically, went up. It was poorly understood as a condition. It was previously used to be thought as a disease mostly for men. Then somewhere around here in the late 90s, if you notice, as it ticked back up, awareness started somewhere over here. And as if you notice, since the beginning till now, men's mortality has significantly reduced. Women's mortality only began to reduce in the recent past, around the early 2000s. So this is a remarkable difference in same condition, same species, the same medical therapy, but awareness plays a big part. And if you look at over here, this came out of UCLA, where you have these diameter circles, and the smallest one would be the odds of war. And if you look at all the different things as you go across in this worm, the largest one by far and large is cardiovascular disease. Cancer is a close second, followed by respiratory disease, but heart disease is a big one. And if we go back to this one over here, where in the late 90s, early 2000s, really awareness became, and this was in the cover of Time magazine about 20 years ago in the early 2000s. And that was really, at that time, they identified the women's biggest worry really is heart disease. It's not so much cancer, even though cancer is obviously very, very important, that statistically you're more likely to die from this. And unfortunately, and this is where our medical literature, most trials underrepresent women and minorities. So if you look over here, in 2016 was the first time the AHA actually released a medical statement on this differential. We always knew about it, that trials favored placing men in trials over women, and we kind of drew a conclusion on that. Unfortunately, in 2016, it said that a woman is more likely to have a higher mortality rate than a man, affected with the same exact thing. So if you're going to get a heart attack, a woman is more likely to have, unfortunately, a worse outcome than a male. And if you look at this, to break this down, 1 in 3 out of women is having a mortality, a death out of heart disease. And that would equivocate to about 1 every 80 seconds. It's very, very serious. And if you take all cancers combined, cardiovascular disease in women still outbeats them despite adding them all up. So this is pretty serious. The risk factors, there's always risk factors, and we'll go over some of these. If a woman is meant to have a heart attack, she's more likely to die in the first year than a man is. And 2 out of 3 women state that they really did not have warning signs prior to the event, so these lead to the complexity of identification. So you have a historical component where there wasn't a very good information and awareness, and then you add the presentation is a little bit different. This is where we look at deaths from breast cancer in the United States. On average, 1 in 31 women end up dying from breast cancer. Compared to cardiovascular disease, it's 1 in 3. It's underdiagnosed, and we really don't do a good job treating it, unfortunately. Women generally are easier to miss, and there's some gender bias as far as saying, oh, this is more likely to be a man's disease. And now, obviously, we know that's definitely not true. A lot of patients that we see in our offices, and this is across the whole country, men come in with chest pain that radiates to the arm. And that's typical for what's called angina, which is an exertional chest pain that is below your sternum, can radiate to different places. In women, as you can see from this diagram, they can come in with a whole multitude of symptoms, and that's part of the reason why it's missed. In men, you don't see that as much unless there's diabetes or other neuropathy involved that affects their sensation. But in women, even absence of diabetes, which alters your sensation of pain, you can come in with cold sweats, back pain, nausea, pressure in the chest. So if you read through all this, you're like, well, everybody's had one of these. You think you're having a heart attack right now if you're a woman when you read some of this stuff. So that's part of the issue. Risk factor is going to be the same. You know, none of these here would surprise you to say smoking, diabetes, high cholesterol, obesity, depression, and stress. None of these would surprise you. If you go through specific gender risk factors, gestational hypertension, our guidelines recently advised that if you see a female in your office, you're supposed to ask about gestational diabetes and gestational hypertension. It's not like, oh, 20 years ago I had that, it doesn't mean anything. Well, it does, because it may increase the risk of getting cardiovascular disease down the line. So these are some of the awareness issues that are coming up now. Smoking, obviously, if you reduce your risk of smoking, this is very interesting, for cardiovascular disease, in about 10 to 14 years, your risk is equal to a non-smoker. So that's pretty serious. So when your patient says, oh, well, I've been smoking for 20 years, it doesn't matter. Well, it does matter, because it helps. Your body has an excellent healing mechanism. So it's beginning to reverse back some of the stuff that was there for all the years of smoking. So I'm not sure it's ever too late per se. Obesity, which unfortunately in most developed countries and westernized nations, obesity is on the rise. In the United States, you know, it's a third of the country. So it's pretty serious that are overweight, and another third is obese, and 6% is extremely obese. So this is a bigger pandemic that is part of it. And in the COVID-19 pandemic, obviously worsened this. Everybody became sedentary, less access to gyms, people ate unhealthy, they snacked way more. And on average, most patients gained a little bit of weight. And we noticed that in their blood pressure and cholesterol over the years that we've had this pandemic now for the last year. This is a really interesting diagram to show you where weight comes into this. You say, well, what does that have to do with anything? So this is just BMI and your risk of death from a cardiac disease. If you see your BMI is in the low end or normal end here, your risk of death is very low. If you go up to a BMI of 32, you see it's a six-fold increase. So it is a significant difference, increasing versus decreasing. And the same thing goes for diet. You have to keep that in mind, that diet. And we always talk to patients about different diet, and patients have this presumption of, oh, I eat healthy. And then you go through, what is it exactly that you eat? There's underutilization of fruits and vegetables in our diet and more whole grains. We don't eat enough fish in most American diets, unfortunately. And there's a lot of refined sugars that we get. So, and minimizing sodium. So unfortunately, all of those, we're not doing a good enough job overall. And we really push for exercise. Exercise is an excellent way to prevent cardiovascular disease. There's an excellent documentary on Netflix. My wife and I recently saw. They went to the different blue zones, which are the areas around the world where people reach their 90s and 100 years of age more than any other places on the planet. And these different blue zones across the entire globe have one thing in common. The people are very, very active, and they have a predominantly vegetable-based diet. They have fruits, they have vegetables, their tobacco is not common, they're not sedentary as we do, and they have a fairly stress-free life. They leave time for exercise, they leave time for yoga, prayer, which is all part of well-being. So I think in a country like ours, where we're always on the run of the hustle and bustle to try to get to the next thing that you have to get to, and you don't leave enough time for yourself, it's really important to say, I need to clock in this amount of time where I take care of myself and worry about my cardiovascular disease. If you take diabetes and add it to the mix, this is women without diabetes, their risk of death. When you take a woman that has diabetes over a follow-up of about 20 years, her risk is over 6-fold compared to women without diabetes. So diabetes is very much entrenched into this. And part of that has to do with, developing diabetes, whether it's diet, it's inactivity, lack of exercise, and stress. I wanted to show this because I always get patients that tell me, oh, I'm just going under a lot of stress. And this is interesting. This was a Northridge earthquake that occurred in the 1990s. And this is the number of heart attacks that people and cardiac deaths that people were getting in the country in 91, 92, and 93. You see, they're all about the same. The day of the earthquake, the number of heart attacks spiked up multifold. I say, oh, well, that's an oddball. And this is to kind of show what does stress do to your heart. If you see this increase in heart attacks in England after the English soccer team loses to Argentina. So this is the day of the match, 1 day after the match, 2 days, and after 4 days, it begins to plateau. And this is a World Cup, obviously. It was, obviously overseas soccer is a big deal compared to this here in the United States. So I think the point we're trying to drive is diet and exercise are extremely important. Exercise is very, very, very important. However, to also keep in mind is time in your life to de-stress, whatever that means, whether it's yoga, whether it's prayer, whether it's time to just kind of take the cell phone and turn it off and say to yourself, I'm gonna de-stress myself. It's really important. It's important if you're a male or female, but especially important for a female, as we saw from the data. The mortality for women is not yet where it should be compared to a man.
So hi, thanks, Yasser. Appreciate the sharing there. That was great and hard act to follow. I'm Ankur Tiwari. I'm one of the cardiac electrophysiologists here. Nice to meet all of you. Thank you for coming. I'm going to try and do the same thing Yasser did, which is share my screen. So give me a moment. Okay, so like I was saying, I'm Ankur Tiwari. I'm one of the cardiac electrophysiologists. Me and Dr. Rudnick are here, and we've recently opened the Center for Atrial Fibrillation and Electrophysiology. Part of that is because we believe that there's more to treating AFib than just seeing you one time and kind of giving you a prescription plan and then having you follow up with some, whether it be your primary or primary cardiologist. We think there's a big benefit with the time, explanation, and follow-up that we can provide with the Center for AFib and Electrophysiology. So today we're going to kind of go briefly over some general stuff about atrial fibrillation, what it is, and how it affects people. I'm sure all of you may or may not know that you know someone with AFib. It's not something that you wear on your sleeve necessarily, but I'm sure most of you probably know someone with atrial fibrillation. So let's start with a little bit about the epidemiology of AFib, which one of the biggest things that affects AFib is age. So there was a few different studies, and we don't have to go into the detail of all of them and the idea of keeping on time, but, and we're going to skip some slides in the same kind of concept here, but basically the older you get, the higher the likelihood that you have atrial fibrillation, okay? Depending upon the study you look at, the Rotterdam study showed almost 20% people over the age of 85 years old have atrial fibrillation. People from 75 to 76 years old, out of one study, 12% of those people had AFib just in that small group, 75 to 76 years old. And the Atria study showed if you're over the age of 80, you had a 9% chance of having atrial fibrillation in that group as well. And if you're 55 or younger, your chances were around 1%. So age plays a big part in whether or not you have AFib. There's a lot of other factors. Men get atrial fibrillation more than women, but not by much, 1.1 versus 0.8%. Race surprisingly plays an interesting role as well. White males are much more likely than others. And again, to Yasser's point, unfortunately, we don't study women enough. And a lot of these studies are predominantly male based. And this, for race, I think we looked at mostly males as well. And like I said, white males more than blacks, Asians, and Hispanic Americans all were more likely to have atrial fibrillation by a significant amount. Geographically speaking, here in North America, we are much more likely to have atrial fibrillation than in the East. Japan and South Korea were the lowest. China was also very close as well. And the numbers of AFib, and not completely sure why, but along the lines of the same risk factors for heart disease are the same risk factors for atrial fibrillation. And so we do see the numbers going up over time. It was estimated in the 90s, mid 90s, that you had about 2.3 million people with AFib. They estimated that in the 50 years passing that would pretty much double in number to about 5.6 million people. So this is just a little schematic of, you can see how much age affects and how deep that slope is for men and women. So this is 40, oh, sorry, I lost my mouse here. This is 40, 50, 60 years old. And then at 60 years old, in all these, you see a sharp trend upward towards having more atrial fibrillation overall, okay? And that's for both men and women there. And then you guys may hear some of these terminology, and so I'll just go over them briefly with you. Sometimes we as physicians get so used to saying something that we quickly say it, and then we don't really realize that we're not explaining it well. And so AFib comes in various varieties, and it all depends upon how long that you have it. So if you have it for less than 7 days and you're going in and out of it, it's called paroxysmal atrial fibrillation. If you have it for a straight shot for more than 7 days, it's called persistent. If you have it for more than 12 months straight, you're chronically in it, it's called long-standing persistent. And if we decide that we're not going to try and get you back into a normal heart rhythm, and again, I'll try and explain what that means in a second, we call it permanent AFib, and we just keep you, and we try and control your heart rate and go from there. People also talk about how you treat AFib. And when we talk about how to treat AFib, we break it up into what we call valvular and non-valvular atrial fibrillation. And basically, it depends on what kind of blood thinners we use. And you guys may know somebody who's on blood thinners. One of the things we try to do here at the center is make sure that we have you on the appropriate blood thinner, and then even possibly try and get you off if blood thinners aren't the right medication for you. People who have mitral stenosis, moderate severe, can only be on something called warfarin, or if they have a mechanical heart valve in the place, then they can be on warfarin. For all others, they can be on various other blood thinners, and there are a lot of different options for that we can talk about. So these are probably, the next two slides are probably the most important slides that we can talk about, and they are what you can and can't do to help prevent atrial fibrillation. Now, many of the things are the things we talked about in the epidemiology. You can't really do something about age. I always hear people say, oh, I hate getting older, I hate getting older. I told them that the other choice isn't really the best. Either you get older or you die. So I'd rather get older. You can't do anything about your sex, your family history. If you have somebody with a family history who has AFib, you have about a 40% increased risk of having AFib yourself. Race, if you're tall, you have more likelihood to get AFib. And any kind of cardiac valvular disease, and in general, any kind of cardiac disease tends to have more atrial fibrillation. And this is modifiable risk factors. So this is what can we do something about? And if we do something about it, can we decrease your risk of having atrial fibrillation? Which the answer is yes. So blood pressure, weight control, obesity, making sure we do endurance exercise. If you have obstructive sleep apnea, which we screen for this regularly now with some simple questions, we make sure we treat it, checking you for any kind of thyroid disease, making sure we decrease alcohol consumption. Alcohol is always a cardiac irritant every time you drink it. So decreasing that decreases irritation to the heart, which could be one of the triggers for atrial fibrillation. Any sort of pulmonary disease affects your atrial fibrillation. Obviously, diabetes, smoking, heart failure, and a heart attack all can have an effect on AFib. Now, This is a little bit too deep in the woods here for as far as mechanism goes. Suffice it to say that the area that atrial fibrillation tends to originate from, and we don't know the exact cause of atrial fibrillation, to be honest, but we know that it tends to come from the area where blood returns from the lungs to the heart. Because of the way the interaction between those two different types of cells are, it tends to be the driver of atrial fibrillation. And as I'll show you a little bit in the future, we try to isolate those areas to hopefully stop atrial fibrillation in one of our treatment options. These are the medications we can use to help treat AFib. They go for both making sure that your heart doesn't go too fast or too slow, and they also try to get rid of the AFib in a way that you can maintain your normal rhythm without having, with just being on medications. Again, this is a long list, but it's just to exemplify what we have at our disposal. That's what I want to focus on. So this was some of the data behind the pharmacotherapy. About 50% of the time, medications work to control AFib. The other 50% they don't. They have a decent amount of side effects that are possible, and we do monitor anybody on antiarrhythmic therapy very close, which means medications to keep you out of atrial fibrillation, okay? There is a more recent study called the East AF-NET study. The long and short of that is early detection and treatment with a strategy to keep you in your normal heart rhythm and out of atrial fibrillation tends to confer better outcomes in the long term. This seemed to go a little bit different in the face of older studies that looked at what was better was rhythm or rate control, meaning I don't care if you're an AFib, I just don't want your heart to go too fast or too slow, versus trying to keep you in normal rhythm. Those old studies says there wasn't much different. The difference that occurred in the study showed that if you treat AFib early, and now that ablation, which we'll discuss briefly, is an option, that you have better outcomes overall. So I just spoke about ablation. What does ablation mean? Ablation is creating an area of scar tissue in order to isolate the electrical activity in the heart. There are two big types of technology that we use to do that. One is called radio frequency. Again, the details here are not necessarily important for this talk, but the idea is to deliver radio frequency energy to the cardiac cells in order to create that scar tissue. And that scar tissue will then isolate the electrical activity and hopefully keep you in a normal rhythm, okay? Now, everybody's heart's a little bit different. So if you came to the center and you decide to go through with this, we'd take some images of your heart. And these are examples of that area that we have to go to. And you can see there's very different makeups in different people of how that side of their heart presents. So it helps us to know what it looks like. And it helps us to help treat you appropriately and make sure that we're giving you the right form of treatment. This is an example, a schematic of what you do in radio frequency. You can see that each of these spots is where I say we deliver that radio frequency energy around the pulmonary veins. These are where blood returns from the lungs to the heart. This is technically where we think that AFib tends to originate from. So we try to electrically isolate these areas and make sure no electricity can get out and no electricity can get in. It's not important. And these are just some examples of my personal procedures that I've done on patients. So what you see here is these are, so when we do these procedures, we take an electrical paintbrush and we put it on the inside of the top chamber on the left side of the heart, and we paint it electrically. And the red is an example of no electrical activity. The purple is an example of normal electrical activity. And these green areas are either scar tissue and or areas of transition. These areas are the sleeves that I kind of related to before that tend to be the cause of atrial fibrillation. So we want to make them electrically isolated. This particular patient had long-standing atrial fibrillation, so making these all electrically quiet tends to confer better outcomes. And so you see in this image that it has become all red, which means it's now electrically quiet. This is someone who had similar kind of presentation. There's another kind of technology we use called cryoablation. In this, we freeze the tissue. And basically it's the same kind of concept, but instead of using that radio frequency energy, we put a balloon into those veins and we freeze that tissue. That freezing creates ice crystals within the cell. Those ice crystals destroy those cells and effectively create scar tissue that isolate it, okay? These are some of the in-drops, and these are some of the results of similarly patients. This is a patient who was in and out of it. And so we just did the pulmonary veins, and this is a patient who had been in it for a very long time, and we had taken out the whole posterior wall. This was one actually from yesterday. I think that's basically it. I know we went a little bit deeper than maybe for this, that was appropriate for this, but if you have any questions, let me know.
So good to meet you all. I'm Christopher Garcia. I'm one of the non-invasive cardiologists here. I'm going to be talking about cardiovascular disease. Man, it's kind of a generalized talk about everyone. I like to call it a crash course in heart disease for the regular person. Let's see. Okay, so heart disease, obviously, you probably at some point have encountered somebody that has heart disease. It's the leading cause of death in the USA for men, but really for everyone. Speaking particularly about men, 1 out of every 4 male deaths is from heart disease, which is an incredible amount. In 2019, 357,000 men died just from heart disease. And 1 out of every 2 men who died suddenly really had no symptoms before. So these aren't people that, were walking around saying, oh, my chest is hurting me or I'm short of breath. They had no symptoms and just passed away suddenly. Sometimes you want to get in to see your doctor or be sent to a cardiologist to see what your risk is. And the best way to know if you're at risk is to sit and listen to talks like this to tell you what to look out for. In the USA, a couple of surprising facts. Every 36 seconds, somebody dies from cardiovascular disease. Every 40 seconds, somebody has a heart attack. 805,000 Americans per year have heart attacks. And that's just talking about disease of the arteries of the heart. There's about 605,000 first-time heart attacks in the USA per year. And, for those patients that go to other doctors, you might hear this term thrown around about silent heart attacks. And that's because patients that are a little bit older or patients with diabetes, and going back to Dr. Elnahar, women, some patients tend to have silent heart events that are only picked up through screening, things like EKGs or other types of tests. So here's a nice little simple slide to look at. You look at the A, which is cardiovascular disease as causes of death. It is across the board for men and women, the biggest cause of deaths. This is in 2009, but if you look through the CDC's data where this is from, you can see that this is every year. And it's been like this for several decades. Our numbers have gotten better as the field has advanced, but certainly heart disease is still the #1 cause of death in both men and women. Here's a different slide. This is from 2015, also from the CDC, that basically shows this is disease that affects people of all races. This is throughout the board for men and women, whether you're Black, white, you're Asian, Latino, you're going to suffer from heart disease. And these are numbers of deaths. You can see it's about 1/4 of all deaths in the United States are caused by heart disease. Here's a map showing that pretty much wherever you come from in the country, heart disease is going to affect you. Of course, you see the South is not doing so well, which is thought to be related to obesity pandemics and kind of cultural food eating habits. But certainly in our portion of the world up in the Northeast, there's plenty of heart disease, and you should be at least screened for it. So what is heart disease? There's a lot of different things. The one that everybody thinks of, which is kind of the most publicized in popular media and culture, is heart attacks and coronary disease, which is plaque buildup in the arteries. But there are lots of other disease. There's enlargement of the arteries of the body, which are aneurysms. There's valve heart disease, which you may hear friends talking about having their valve fixed because it was tight or leaking. There are electrical heart problems like atrial fibrillation that Dr. Tiwari just spoke about. There's heart failure where your lungs are filling up with water or you can't do as much. The heart is weakened or stiff. There are thickened hearts. And then there's disease of the actual lining of the heart, which is actually quite common after viral infections or certain autoimmune diseases. And particularly with the coronavirus pandemic over the last year and a half, we've been seeing a lot of these kind of more uncommon ones pop up around the time of infection and certainly following. So this is, again, just kind of talking about the different types of heart disease and some of the symptoms. So you may have heard, your doctor say, oh, you have a murmur, and that might be due to valve heart disease, or you're having some sort of chest discomfort. I don't say pain because not everyone has pain. As signs of blockages of the disease, swelling, shortness of breath. You might feel your heart beating irregularly or feel pauses. But these are some of the many, many types of heart disease that exist. These are some potential symptoms. Of course, you have the classic, we call this the levine sign, where somebody's holding their chest in discomfort. I want to point out, because I can't tell you how many times that we've had patients come in, particularly men, because we don't tend to not go to the hospital as easily sometimes. And they've been having symptoms for several hours or days before coming in. So heart disease is not always classic pain in the chest. You can have a number of symptoms: upper back pain, neck pain, jaw pain. I've had patients with toothaches that just persisted and kind of radiated down the arm pain, numbness and tingling in the arm, heartburn, indigestion. You might feel short of breath, dizzy. It's a lot of different symptoms. And so what I tell my patients is if you're having any symptoms from head to the abdomen that just doesn't go away, sometimes it gets worse when you're doing things. It's lingering, it's nagging at you. You feel that something is off, you go get checked out. And that's kind of a safe rule of thumb to follow, because people don't really present the same way. These are, again, some risk factors for men, but also for women. I threw in a couple that are asterisks, which are more particular to men. But having high blood pressure is something that you want to get under control, because it does raise your risk for most of the types of heart disease I talk about. High cholesterol, your diabetes levels and control of the diabetes you want to be on top of. Your weight, abdominal and visceral fat has been shown to correlate with poor outcomes for heart disease. So this is something that we've all had trouble with, but you want to stay on top of. And I'm not telling you to go to the gym, an hour a day, but certainly to walk even 20 minutes a couple of times a week helps to keep weight down. Erectile dysfunction is something that's probably not often asked about at your visits. I think there's a bit of kind of a taboo around it, and people feel uncomfortable. It's an uncomfortable topic to some people, but this is something that if you're experiencing as a male, it could be a sign of vascular disease in general. And so it's something that you want to mention to your primary doctor, and certainly mention to your cardiologist if you're experiencing, because it can be a sign of vascular disease and by extension heart disease. And the same goes with low testosterone levels. Cardiologists generally don't treat low testosterone levels, but if you are somebody that has low testosterone levels, either being managed by your primary doctor, an endocrinologist, or urologist, that might be a time to say, hey, do you think it's worth it for me to go get screening with a cardiologist and see what my risk is, as low testosterone and ED are both signs of vascular dysfunction. And again, like everybody else has been saying, family history. And, the family history that we kind of think of as classic is a history of heart disease in mom, dad, and your siblings. Certainly a history in uncles and grandparents also plays a role, but the biggest family history is if mom, dad, or brothers and sisters have had heart disease, you might consider coming in to be evaluated. Excessive alcohol use, which currently we define as more than 2 drinks a day for men, more than 1 drink a day for women. And I like to put a caveat on this for my patients. I'm not talking about huge cups of drinks. That's probably over if you have one really big cup. This is a couple of ounces per day is tolerable, and anything more than that is really too much and can be an irritant for things like AFib, like Dr. Tiwari had mentioned. Smoking, if you're still smoking, I implore you at least cut back. But ultimately, you want to come off of smoking. Significantly increases your risk for strokes, heart attacks, and then other diseases like cancers. Unhealthy eating habits, diets high in fats, salts. This is the cooking oils, the butters, the processed foods, any sorts of frozen foods. When you go out, you have to be really cautious. Inactivity kind of goes hand in hand with the obesity. And then, as Dr. Elnahar was saying, stress and mental health really does play a large role. There are multiple studies that show that depression, anxiety, particularly if uncontrolled, lead to worse outcomes for all sorts of heart disease. So what is your cardiac risk, your individual cardiac risk? And that's the question that you really want to know. And so how do you find that out? There are some online resources that you can use personally. If you Google 10-year heart risk, 5-year heart risk, overall heart risk, there's some things that can come up. But this is really a detailed thing to do. And so if you're worried about your heart risk, you should talk to your primary care doctor and maybe consider seeing a cardiologist. It really requires a detailed history for men, speaking about things like erectile dysfunction, testosterone levels, your family history, kind of social habits like smoking, how much alcohol you use, how much exercise you're getting in, a thorough physical exam to look for swelling, listen for heart murmurs, coming up with a plan to identify your risk with different sorts of blood tests that we have, and then different sorts of imaging tests, exercise stress testing when it's appropriate, things like calcium scoring to see if there's calcium in arteries. These are all things that we can use to define overall risk for you as an individual. And then how do you reduce that risk? Well, a lot of the things, like I said, you lower your blood pressure, you get your diabetes under control, you clean up your diet, you exercise, you quit smoking if you're still smoking, you limit your alcohol, you lower your stress. And then you meet with your primary doctor or cardiologist to see if there are any medications that you should be on or any tests that can be done to kind of prevent the development of heart disease in the future. So that's all. That's kind of my crash course in heart disease. It affects men and women, and some of the specific things that men have to look out for are issues with sexual performance, erectile issues, low testosterone levels, but certainly a lot of these cross over between men and women. And if you think that you'd benefit from seeing a cardiologist to identify your risk early, then you should probably ask your primary doctor about that.
Dr. Tiwari, do you want to address that question about the AFib and ablation? Okay.
That's just the easiest.
We're both vaccinated, so we're good. All right, so I believe your question, Alex, was what do you do? What are your options if you've been through multiple ablations and you still have AFib? Is that correct?
Yeah, so what's the latest treatment, and where would it be conducted if it were surgical or whatever?
So again, it depends on, I don't know what's been done, what kind of ablations. There's various kinds of ablations we can do. When people are truly refractory to the most common type of what we call an endocardial ablation, they've usually gone through 2 or 3 of them. There's a procedure called the convergence procedure, where I, as an electrophysiologist, go on the inside of the heart and take a look and make sure that the inside of the heart is well patched up and that we've taken out as much of the structures as we can to prevent atrial fibrillation. A surgeon, during a separate procedure, will then go in on the outside of the heart and do an ablation on the outside of the heart on the posterior portion. That's probably the most common thing for someone who's really had refractory atrial fibrillation and is very, very symptomatic. If you're to the point where you've even done that and that still doesn't work, what we typically do if you're symptomatic is something called an AV node ablation, where we disconnect the top portion of your heart, which is atrial fibrillation, from the bottom portion, electrically speaking. We give you a pacemaker so that your heart doesn't go too slow. And that's a very effective way if everything else has failed at controlling AFib. Where can that happen? We do most of that here as well. So And then pretty much any place that has an electrophysiologist does that. Not many people are versed in the convergence procedure. That's somewhat new. And that's something, if you'd like to talk about more, we can talk about it maybe off screen.
Okay, fine, thank you. I have an appointment next week with Dr. Rudnick, so
Right.
this has
There
been
you go.
good background for me. Thank you.
I've got another question here about stents. I don't know which physician wants to address this. Someone had stents inserted 10 years apart. Do they have a lifespan, and how do doctors determine if they're still effective?
So symptoms is the best way of determining if they're effective. There are some weaker recommendations for just stress testing in asymptomatic patients, but for the most part, that's kind of a thing of the past. Probably in the 80s and 90s, people were going in for routine stress tests. That's not done as much anymore, and now it's largely symptom based. And your stents, it's very variable. I mean, I've had patients with stents for many years, certainly over 10 years. I've had patients with stents in 20 years that they've lasted. And a lot goes into it, like your control of your diabetes, your cholesterol level control. If you have poorly controlled diabetes and really high cholesterol levels over years, your stents aren't going to last as long because you build up plaques in those, just like you did with the native arteries. But if there's any concern over that, you can talk to your individual cardiologist who would be able to give you a better idea as to whether something's changed on your electrocardiogram or whether you have new symptoms to suggest that there's an issue with one of the stents.
One of the things I always tell my patients is that you're your best early detection thing. So if you are exercising regularly and you notice that your ability is going down, you're more short of breath, you have some chest pressure, whatever that may be, that's a good sign to come in and get checked out. But if you're sitting on the couch, you may not notice those changes. So doing regular exercise is obviously one of the best ways to kind of make sure that you're healthy, but it's also a really good way to make sure that everything's working as it should.
Great. Got two more questions, and I think we're out of time. My mom is 98 with AFib on warfarin for about 13 years. My dad died of a heart attack at 57, over 50 years ago. I'm 65. Does any family history come into play for me and my risk factors for AFib or other heart issues?
I feel like it was a word problem from like grade school, but the short answer is yes. The family history does come into play for AFib. Any history of AFib puts you at about 40% increased risk of having it. Your father having heart disease at the age of 52, I believe you said,
53.
that's premature heart disease. So that puts you at advanced risk for heart disease as well. So I'm probably stepping into Dr. Garcia and Dr. Elnahar's area here with the heart disease portion. But for AFib as well, it does put you at increased risk, I think, is the short answer to your question.
Okay. And the next one is, I've read that red wine is good for the heart. Is this true or false?
So they do have some studies, as you can imagine, mostly from Europe, which shows that there may be some benefit to a glass of red wine with regards to cardiovascular disease. It's important to know that the drinking that they culturally are accustomed to is a bit different, and portion size tends to be a bit different. And their portions tend to be much, much smaller. And so a glass of red wine in European standards tends to be much smaller than a glass of red wine that we would have here in the States. And so, with the benefit to red wine, I say if you're drinking it because you enjoy it, then that's something that you seemingly can safely continue. But I wouldn't recommend that if you're not drinking red wine that you pick it up because you're looking for health benefits for your heart. I mean, that's kind of the general rule that we follow.
I get this a lot because I often say that you should have alcohol. It could be a trigger, or at least decrease it. One of the important things when I looked up this whole data, and this has been reported a lot, that red wine's great for your heart. And I forget, I want to say it's the tannins, but I'm not exactly sure what it is. But the healthy part of red wine, there's 10-fold more in a cup of black tea than there is in red wine. So if you're looking to help your heart out, tea is much, much better for you than a glass of red wine at night. So to his point, if you're just doing it to help your heart out, don't drink red wine. Drink some tea.
Okay, well, with that, I just wanted to say thank you to the doctors for participating with us today, and thank you to all the Wellness Center members as well. And
Thank you for having us.
Thank you guys for having us. Thank you.
We're all available, just give us a call and we'll be happy to talk. So thank you a lot for having us.
sounds great. Thank you all. Have a great day.
Bye.
Great presentation. Thank you so
Great.
much. Bye-bye.
Very good, very good.
It was awesome.